Hey, what's up, y'all? My name is Charles, administrator with Charlotte Health Services. Thanks for hopping on to our Hospice Live 101. We've been doing this for the last couple weeks, and the heart behind it is to educate families on what is hospice. We do home health and hospice and personal care in the DFW Dallas Fort Worth Metroplex. And what we've seen over the last several years is that there's just not enough education about hospice because the word is super scary, honestly. But also, it's hard to digest, especially when you're in the moment. So, these weekly hospice lives will be just educating families, loved ones about what is hospice, and actually giving you a scenario and a situation of a patient that we've had in the past, reorganizing them for HIPAA purposes, flipping them to be a male or female, and so that you can step into their shoes and see yourselves potentially in their situation and hopefully relate. And then after we talk about their story, I'll pretend like I'm walking that loved one through a Hospice 101 education session. And then at the end, what we'll do is just answer some questions that we have from the audience. And so if you're on this, you may be watching on YouTube, you may be watching on LinkedIn, you may be watching on Facebook. If you're on IG or Instagram, it's going to be like this. And so some of the clippings may not be visible, so you can hop onto the other channels and you can watch that from there. So let's get started. So here's an interesting fact that a lot of people don't know is that on average, there's about 2 million, specifically 1.8 million people or patients on hospice annually. And of that 2 million beneficiaries or patients, only 50% of them actually use the whole breadth of the benefit, which is about 6 months or less. But sometimes there's patients who are on hospice a lot longer. The average, if you could see in the stat there, is 18 to 21 days. And so a lot of families and loved ones don't get to experience the fullness of what the hospice benefit is. And so that's what these sessions are all about, specifically to walk you through what hospice is so that you can make an informed decision, if it is the right decision for your loved one, and guide them through those situations, which can be kind of tense and hard. So just getting that information way before the time is needed. So we're going to walk you through a patient. These Hospice 101s are real stories retold. So we're going to talk about Mr. Marcus Hillman and his story and who he is and his scenario specifically when it comes to him picking hospice or his family going through that. So this is Marcus. This is way back when he was younger and strapping, handsome guy. And so let's talk about Mr. Marcus. So Mr. Marcus Hillman was 58 years old. He grew up in Savannah, Georgia, learned carpentry from his grandfather. Later, he owned a small custom furniture business, and he was able to make a whole bunch of things for the community, which was really awesome. He married his sweetheart, Denise, who was a pediatric nurse, and they moved to Dallas, and they raised their 3 kids, Aaliyah, Marcus Jr., they call him Jr., and Ben. And he actually rebuilt the home with his own bare hands because he was so good. And he redid the home himself, and they lived in that home. And Marcus was the go-to guy. If anything was broke, fixed it. And the neighbors were like, hey, my toilet doesn't work. They would call Marcus. He'd go over and he'd fix it. And that's just Marcus. He was the go-to guy, and everyone knows Marcus for that specifically. And so one interesting thing happened was that around 40, and when he was about 58, he saw that his grip strength wasn't as strong anymore. And it was kind of interesting because he was like, this is weird. I can't grip as much anymore. And so him and his wife decided to go to a neurologist. And the neurologist detected and did some tests and actually gave the news that he had ALS. And they were like, what is ALS? What does that mean? And for those of you who don't know ALS, it is, in very simple terms, it's a disease, a degenerative disease that basically stops communication from the brain to the spinal cord to the muscles. So your brain is active, but it's not able to control your muscles and movement. And unfortunately, your body begins to waste away over an amount of time, which nobody knows the time period. And so he was like, wait, what do I do? Like, how do I go through this? So they had to like go through that process of understanding, okay, I'm still okay. I still have my cognitive availability to make decisions and to do things. Like, what do we do? So the neurologist recommended home health, and so we took care of him on home health services. And so, what does home health look like? So home health is having a physical therapist come out, nurses come out, and to really help with maintaining the muscle strength that he has, so he doesn't atrophy or his muscles don't decrease faster. And so he did a whole bunch of bouts of home health and did pretty good, honestly. And the biggest thing with him was that making sure that he can continue to do his daily activities. But what happened was, is at first it actually started to slow down, and he actually had more bouts of exhaustion, and it became difficult for him to actually button his shirt. The dexterity or the ability for him to do those things with his hands that he loved to do was super hard. And it got to the point where he started using a walker over the years, and then a wheelchair, and it became difficult for him to breathe using a BiPAP machine and a cough assist machine. And it just kept getting more and more intense. And the biggest thing about Marcus is that, he loves his grandkids, and the things that he used to do, he couldn't do anymore. And that's a hard place to be for anyone. Imagine you yourself, you're able-bodied, you're doing everything, you're driving just to the grocery store, you're driving to Kroger, or Sam's or Costco, if people are Costco fans. There's a Costco and Sam's war going out there. But you can't do that anymore. Like, it's you lose your sense of, who you are. And that's where Marcus was, and struggling with that while at the same time declining. And so one of the biggest things that was happening is that he had more hospitalizations, and his pulmonologist spoke to him and said, hey, you're declining rapidly, and this ALS now is actually progressive, and it may be time to consider hospice. And now the family's like, what does that even mean? And Marcus at that time couldn't really say that much, but he's able to type. He wants to be at home. He doesn't want to go back to the hospital anymore. He wants to be at home. And Denise, his wife, was really like, does that mean he's going to die tomorrow, right? And so that's where hospice, the fear of hospice becomes very unknown, and not knowing what hospice is very difficult. So if you're following this, if you just hopped on right now for the very first time, we are doing a hospice live. We just went through a scenario, a real story, but it's retold, of Marcus, and we're talking about his story with ALS. And you guys know the Grey's Anatomy star recently passed with ALS. And ALS is just a really difficult and still unknown disease. There's a lot of research going into it, but the diagnosis is just heartbreaking. And so, what we wanted to do is just highlight and walk you guys through this, so you understand what is hospice with ALS and what does that even look like. And so now, Denise calls our office, and they get the order from the doctor, and they say, hey, you need to start looking into hospice. And so she's like, I don't know what to do. So she goes into Google, types in Google, and says, okay, what is hospice? Plano, Texas. And all the agencies popped up, and she starts calling. And so a lot of times when families are trying to figure out what is hospice, what we like to do and what the best hospices do is that they walk the families through a hospice 101 and educating them on what is hospice. So when you're thinking about hospice, it's really focusing on specific criteria, but from a very basic standpoint, it's managing pain symptoms, emotional and spiritual support, and supporting family through end of life. And a lot of times hospice can happen in several different places. It can be at the home where your loved one may reside. It could be in an assisted living facility or a senior living facility, or group homes, which you may be familiar with, where it's like a home where there's several different people in that home that's licensed. Or it could be a skilled nursing facility, inpatient unit that has hospice there as well. And so what happens is that once your loved one or someone is meeting that criteria, the doctor will write an order and say, hey, this is what you should probably consider, because all the signs are showing that you may have 6 months or less to live. That doesn't guarantee that your loved one's going to pass in 6 months. So when Denise talked to us, we talked to them and walked them through basically three main things or three main parts when you are talking about hospice. So the first part is the care team, second part is supplies, DME, and the last part is medication. So what we're going to do is we're going to tailor this towards Denise and Marcus's their specific situation, because every patient has a story and everything is not cookie cutter. The best hospices, what they do is they tailor towards the family and tailor towards what the needs are. And so in this situation, let's talk about the care team, which is the first kind of part of the three parts of hospice that really help to understand what it all entails. So when you are admitted to hospice, you get a care team, and you get the main person is really the RN or the nurse who's like the quarterback. And that quarterback, that nurse, what she does is she's in charge of creating care plans to focus on what's going on with your loved one. So now with Marcus, Marcus wants to be at home. He wants to not go to a facility. He wants to be there, and he has his family, his son, his daughter, everyone is there to help, and he wants to be at home. So now the nurse is going to tailor those goals towards him being at home, and the goal is that he would pass at home. So now the nurse would then go out, do the admission, review all of his medications, and create a care plan, which involves these other people that you see on the screen: an aide, a chaplain, a social worker, and the medical director, the doctor who oversees all of the services that are provided under hospice. So he saw his pulmonologist, he saw his neurologist. So the pulmonologist is the one that wrote the order for hospice for Marcus. So now when you sign on to hospice, you can pick and choose whether or not you want the hospice's doctor to be the attending. And most of the time, that is usually the case that families go with, because the hospice doctor is experienced and well-versed in end-of-life care and hospice and pain management. And so what happens is that loved one or your family assumes underneath that doctor, underneath the hospice care team. So that's kind of the really quick nitty-gritty of the care team when it comes to caring for Mr. Marcus. The second part of hospice, the second basically meat or core value or core part of hospice is medication. So when you're looking at medications, that nurse will then go out, do the admission, review all the medications that Marcus is taking. And so based on his terminal illness, which would be in this part ALS, all the medications that are assigned or coordinating with him would be covered underneath hospice. And if he has any other medications, what happens is the best nurses, the best hospices, what they do is they educate Denise on, hey, these are the meds that hospice will cover, and these are the meds that hospice won't cover. And if they don't cover, then insurances will pick up, or based off of how he's doing, they may recommend to say, hey, his now let's focus on quality of life. All these meds that he's taken may be conflicting against how he's doing in his body as he's declining. So let's discharge maybe a few of these meds if you're okay with it. And that's kind of how that process goes. And depending on the hospice, sometimes they will drop ship all those meds to you at the house, or they will coordinate with the pharmacy. In this case, Denise, she still wants to feel active. So she wants to continue to go to the pharmacy and pick up those meds. And so that's where sometimes the hospice will coordinate and tailor towards the needs of the family. So that's medications in a quick nutshell. Next part is we're looking at DME and supplies. So all of these are covered. So we talked about all of these. There's no cost to hospice, which is a big thing when it comes to end-of-life care. Medicare Part A covers that 100%. So when you're looking at the DME side, if he needs a walker, if he needs a wheelchair, if he needs a hospital bed, a lower loss mattress, the hospice has basically a formulary or all the supplies that are covered. And then you can basically pick, and then they'll drop ship or deliver those DME equipments to you. And then, once your loved one passes, then they can retrieve that back. So you don't have to pay for those things, which is a big deal. Depends, chucks, wipes, those are all covered as well by hospice, which is a big deal as well. And so those really help families to kind of take the strain and the stress of, oh man, I've got to buy this Depends. I've got to buy these gloves. I got to buy these wipes. But there's a list that the hospice will give you that is covered. Anything outside of that, of course, you're more than welcome. The families are more than welcome to buy out of their pocket as well. But these are the things that are covered under hospice, under Medicare Part A specifically. So that's the DME side and the supply side. So when you're thinking about this and you're considering, now Denise has got all of this information and she's done this hospice 101 and she's like, where do I start? What do I do next? And so now we're going to go back to where she was in the hospital and kind of go back to what we just talked about, right? So recognizing that it may be time is the first step. Getting the doctor's order, which the pulmonologist sent that out to Denise. Choosing the hospice provider. So it's very important that you take time to find the hospice that matches your needs. Now, there's no perfect hospice because we're all flawed. We're all human beings. Just like there's no perfect restaurant. There's going to be a part of the restaurant where you're not going to be pleased with, but it's all about the management. It's all about how it's run. And it's important to pick a hospice that you feel that can tailor towards your needs, because all hospices are really doing the same thing when it comes to that Medicare benefit. It's just making sure you find the one that fits the best for you. And then the admission starts. And then when the admission starts, that's where the nurse goes out. And so we're going to go back a little bit just really quickly. And before someone starts hospice, there's these qualifications that have to be met. So for Marcus, his ALS diagnosis is a terminal diagnosis and he qualifies. But there's some people who don't have that, of course, disease. And then you see over there, you've got the heart, you've got the lungs, you've got the brain, you've got blood, you've got that little man with the little walker. It's like debility and weakness, and failure to thrive is kind of like a term that's been used, but can't be used specifically when you're admitting a patient. But it's like a culmination of all of the different types of comorbidities that are ailing your loved one. And the last one is cancer. So within all of these, there's specific, they call them LCDs, or there's a specific things that have to be met in order for your loved one to qualify. So let's say Marcus didn't have ALS and he had some type of disease, let's say a general disease, let's say CHF, and he constantly went back and forth to the hospital. So in order for him to qualify for hospice, there's specific metrics that had to be met. So the doctors who write the order, they'll send it, but it's the job of the hospice to qualify them for that hospice benefit, which is very, very important to understand. So when it comes to qualifications, one, then there's insurance and who pays for hospice. We talked about this a little bit earlier. Medicare Part A pays for hospice care. Now, let's say you're younger than 65 and you don't have Medicare. Depending on your insurance may have a policy that actually has a hospice benefit. And if it does, not every hospice is contracted with that specific insurance. So in those situations, what you have to do, sometimes the safest and quickest thing to do is to reach out to your insurance carrier and ask them to provide a list of all the agencies in your area that are in network with that hospice, with that insurance, to provide those services. And so underneath Medicare, like we talked about, it's 100% covered. Now, if you go outside of what the scope of hospice is, which is, sometimes if you want to do aggressive treatment or do procedures, now that's may not be the time for you for right now for hospice. So in Marcus' case, he did home health for a while and he wanted to continue to move forward, do treatments, do tests and studies. And he did that for a while. And then he came to the point where he was like, I'm done. I just want to be at home and live my life as long as God gives me. And so that's when hospice is appropriate. So it all depends on each family and what their goals are and what your goals are when it comes to hospice care. So now Marcus is at home now. He's at home on hospice, and he's able to live his last days under hospice at home with that support. So he has the clinical support of the whole care team. He's got the supplies that are there. He's also has DME equipment, maybe a cough assist machine to help with his breathing. There's a lot of things that are there to help support. And the one thing that we always like to say to families is that hospice is not there to take away the problems of life. It is there to help support through the turbulence that you may experience with the disease, with end of life. And it's just like when you have a baby. Uh, I've never had a baby. I haven't had a baby myself. My wife has had a baby, and we have 2 kids. Um, but um, but just like having a baby, you have support, right? And so there's so much emphasis with the OBGYN and prepping for a baby and having those nurses around you and doing breastfeeding classes and all these things, right, for that day. And so that support is just like hospice as well. And that support is necessary for families to go through that season of birth and go through that season of end of life. And so now, when you're thinking about Marcus's story, his story is the story that he wanted. He knew what he wanted, and it's so important to make sure that it's hard. I'm not gonna lie, it's hard to have those conversations with your families or your loved ones when you're talking about end of life, but it's important so that you can honor their wishes and you know exactly what it is that they desire and what they want to do. So we're talking about also there's the continuum of care in this situation where we talked about hospice, which is healthcare at home, hospice, palliative care, which is different than home health or hospice care. It's a tailored approach where you can continue to do aggressive treatments, patients who have chemo or want to do different specific aggressive treatment. Palliative care is there to help provide that, but a lot of times when palliative care ends is when hospice starts. And so then you have personal care, which is now we talked about the aid coming, but now the aid only comes for a limited amount of time during a week that's covered under Medicare. So anything outside of that is covered by personal care, which is out of pocket, private pay, or long-term care insurance, or the VA. And then you have home health, which Marcus was on for a while, which is skilled nursing, therapy, PTOT, and helping him to decrease the amount of atrophy that was happening with his ALS and with his disease. So I know that's a lot of information, but one of the things that we want to make sure that if you do have questions to reach out to us, and I think we have a few questions that may have hopped on. We've got JT in the back as well and Tina, so I'll see if they have a few questions that we can walk through regarding Marcus's situation as well. Let's see. All right.
You hear me all right?
Yeah. Hey, what's up, JT?
This is.
Oh, can you come up? There you go. Go ahead.
Can you hear me all right?
Yeah, perfect. Sweet.
So specifically with ALS patients, we've had patients needing more equipment than what typical hospice requires.
Yeah.
How does that work? Does Medicare cover like cough assist device, non-invasive ventilators, and things that ALS patients may need?
Yeah, great question. So each hospice runs a little bit differently, so it's so important to ask those questions ahead of time. So when you're talking about cough assist and you're talking about devices, usually the hospice will contract with the DME company, and it's good to ask those questions ahead of time if the goal is for, like in Marcus's case, to be at home. So the goal is to keep him at home and not have him go to the hospital or go to a unit. So the hospice is, that's where the interview comes in to talk to the hospice and say, hey, if my goal is to keep him at home, is this something that we can do? And in those situations, the hospice will guide the family through about, yes, this is the machine, this is what we do, and then walk them through that. So it's very important to ask those specific questions. But yes, it can be done, just like in Marcus's case, where a lot of those devices can be helpful for a family at the end of life at home.
Sweet. Thank you.
Yeah.
And then a question we got on LinkedIn was about treatment for ALS.
Mm-hmm.
So hospice, you talked about how it focuses on comfort.
Yes.
What about the different drugs that are used to actually treat ALS once hospice starts?
Yeah, so it all depends. Like, so specifically when you're thinking about hospice and ALS, the neurologist, the pulmonologist, all the doctors specifically will recommend specific medications to help a lot of times with that pain and comfort. A lot of times when we see, in our experience with ALS, it's the breathing and discomfort. And so a lot of those medications are sometimes what they call comfort kits. It's really there to help guide and alleviate the discomfort that patients will feel when you're looking at ALS. So, specifically, what we like to do and what hospices do specifically is that ask those questions to your nurse or to the nurse that you may be having questions to so that they can walk you through the specifics of hospice when it comes to clinical guidelines. For this, we just kind of talk about the overall arching information, but from a medical standpoint and from a nursing standpoint, going into the weeds, it's so important to talk to the hospice nurse or the nurse that is walking with you through home health as well.
Yeah, thank you. And I think just to kind of clarify, home health versus hospice for an ALS, we talked a lot
Yeah.
about hospice today, but what are some things that a family may be holding on to or trying to do that would make them want to maybe stay with home health, at least at this time?
Yeah, so when home health is, you're looking at a lot of therapy driven progressive treatments. And so when you're looking at home health, there's going to be a lot more emphasis on therapy visits and trying to do more visits during the week. Hospice doesn't do that. There are some hospices that contract and have therapy, but it's not that many because the goals are a little bit different. And if a therapist does come out, it's usually maybe once or twice a month just to help with positioning or guidance here and there. So the goals will look a lot different when you're talking about home health. So you can have a therapist coming out a couple times a week, OT specifically when we talked about Marcus and not able to do those ADLs and just kind of giving exercises or using splints or using techniques that can be taught to the family to help with that, to maintain his quality of life on home health. That's where you see home health shine when it comes to ALS. And then on the hospice side, that's where it's now more comfort measures. Let's say there's not that much that can be done from a home health standpoint. It's almost like a plateau because the disease has taken so much of a toll on Marcus specifically. And so now it's a reverse of now let's keep him comfortable. Now let's get aid services in there 3 to 5 times a week to help with bathing for 30 minutes. And that's where that support is helpful for families so that that load is not all on the family now. So it all depends on what the goal of the family is. But those are the differences when you're looking at home health and hospice.
Awesome. Sweet. I think you answered all our audience's questions today.
Awesome. Well, hey, we appreciate you guys. Thanks for hopping on. We'll be back again next week, Tuesday, and we'll talk about another patient situation and a patient scenario when it comes to hospice and understanding what hospice is as a whole. So God bless. We'll see you guys next week. Have a good one. Bye.